give them any sort of care. So for example, if you're like dealing with someone who has pepper sprayed and they're gonna be like screaming, like it's gonna hurt a lot, you can't just go and give them water and start spraying their eyes. You have to ask, hey, can I give you water? Hey, can I give you saline? And things like that. And when you're caring for a patient, always verbalize everything you're doing so the patient feels comfortable. So that means like if you're caring for someone with a cut, tell them, okay, I'm gonna wipe your wound now with an alcohol wipe. Okay, I'm gonna give you antibiotic ointment now. Okay, I'm gonna bandage it up with a Band-Aid now. So they feel comfortable and they feel like they're in control of their situation. And also, especially at a protest, scene safety is really important. Before you start giving care to a patient, always assess for scene safety and always assess for your personal safety first and foremost. Because if your own person is not safe, you're not going to be able to give good care to the other person. And usually you're going to have to want to make sure you have someone else with you so you can take your patient out of dangerous situations. And if you don't have someone with you, point to a random person and just like be like, hey, can you help me get this patient out of this situation? If like the cops are shooting at you, don't just start caring for your patient right there. Get your patient out of the area first and then start caring for them. Yeah, and I also want to stress like being a street medic is like completely different than just being a protester or being a frontliner. Being a street medic, you do have different responsibilities than just being a protester, and a lot of it is calming people down in situations. So even if you're in high stress situations, you have to kind of control yourself because you're kind of in control of calming everyone down who might be hurt. And if you're like stressing out in a situation where you're caring for a patient, that might make it worse for them. So yeah, and also like you might want to like at protests, like you might want to like do something, you might want to like fight someone, but like you have to always like remember, like as a medic, your responsibility first is to the people around you. And if you endanger yourself, you're endangering the people around you. So if you do things that like make you a target by the police or anyone else, you're endangering the people around you, because if you have to like exit from the protest because you're too hot or something, like that puts the group in danger because they no longer have a medic. Okay, so basic street aid. So like projectile wounds, like for example, like rubber bullets, pepper bullets, all that. If it breaks the skin, do basic like cut care, which is like basic cut care is just wipe with an alcohol wipe, dab antibiotic ointment on. You don't want to put like a big glob or like a whole line of antibiotic ointment. Just dab it in a line. So like give them like minimal antibiotic ointment that will cover the wound, but not too much. And just like cover with a bandage. But if the projectile wound doesn't break the skin, then there's nothing much you can do for it. It's just gonna be a bruise and it'll heal over time. For pepper spray, only use water and saline. I know there's like different like solutions, like the baking soda solution, like antacid solution. Don't use any of that, because also just for your patient's comfort. Most people, they want to know what's going into their eyes, and most people like they don't really know how you've combined the baking soda solution. They don't know how you've combined the antacid solution, and that might be a point of anxiety for them. So I would say always just use water and saline. And also these solutions, they also can scratch a person's cornea. So it's dangerous to use, because if you also mix the solutions wrong, that could cause eye damage for your patient. Don't wipe your patient's face with any wipes, because that's gonna rub the pepper spray and the tear gas into their skin. So only rinse with water and only rinse with saline. And I usually carry like these little dish soaps that I send the patient home with. This gets rid of the oils from the pepper spray faster than other body washes, and it's just more effective. Sometimes if the patient wants to stay on scene after they've been pepper spray, I'll dab this onto their face so the oils can start breaking down their skin. But never dab it onto their forehead, because when you rinse them with water, that's gonna come down into their eyes. And also like never, when you're like rinsing out a patient's eyes, never rinse from the forehead or above the eyes, because if there's pepper spray up there, that's going to rinse down into their eyes. Okay, so it looks like it usually comes in a box like this. This is just a generic name brand for Narcan, but the actual chemical is called naloxone. It can come in like other brands as well. This is just a more generic brand. And they look like this. Each box has 2. So Narcan is used during an opioid overdose, and you have to identify that the patient is going through an opioid overdose. So what this means is that check their breathing. Their breathing is usually slow and erratic. Open their eyes, check their pupils, and their pupils will be pinpoint pupils. It's not just like small, it's gonna be like pinpoint pupils, really, really small. Check the inside of their lips and check their fingertips for like any sort of like lack of oxygen. You're gonna see this if like the inside of their lip is like bluish or grayish, or like the tip of their fingertips. And they also have to have like a really slow heartbeat. That's a sign of opioid overdose as well. And you're usually going to be able to tell from the scene around the patient if it's an opioid overdose. Like check for any sort of needles, ask any bystanders if they saw anything, just like anyone around. Like usually it's pretty identifiable by the scene itself. So when you're using this, just like put it up to your patient's nostril and just give 1 spray in. After that, monitor your patient for about like 3 minutes. If your patient doesn't show any sign of recovery, take out the second one and give them another dose. And assess your patient for like another 3 to 5 minutes. And they should probably start like waking up by this time. But the thing is that Narcan only reverses an opioid overdose for 15 minutes. So after that, they're gonna start regressing again. So when you start dealing with an opioid overdose, you're always going to want to call for EMS backup so they can arrive on the scene when your patient starts like going back into the opioid overdose, because you're not going to have enough Narcan to like completely usually like get someone back. Any like questions, concerns at this point? Yes.
Is the Narcan bottle of 1 dose?
Yes, each one of these is 1 dose, so you don't give like 1 in each nostril. It's just, yeah, 1 is just 1 dose in 1 nostril. Also, if anyone has like anything they want to like jump in and say, just like feel free to do that. Any tips they want to give and any questions. Yeah, yeah, there's one more right to remain on scene. I'll take a baby wipe, get some dish soap, rub the dish soap in the baby wipe, and then dab it on their face. Okay. Too much pain to do that. I think most people are going to ask for you to rinse their face away. But if they want to do that, you know, that's up to them. That's completely fine as well.
So like if they're intolerant to pain, you can do that to get rid of it?
Yeah, but like usually I think they're going to ask you to rinse. But if they want to do that, that's completely fine. If there's like professional mace sprays, like, you know, go for it. That's fine as well. But yeah, just like also just like get consent from your patient before you use that. Like tell them what you're using on them. If they're okay with it, by all means. If they're struggling to breathe, also try to give rescue breathing. That might help.
Is Narcan available over the counter?
Not that I know of, but if you're if you're like arrested at Twin Towers, they do have the dispensing machine. What were you gonna say?
Oh, I was gonna say something about pepper spray, but yeah, the dispensing machine. If you ever get arrested, you can get free Narcan.
Please get it, y'all. People need it.
Yeah.
All right, I'll get arrested today.
Seriously, there's no limit.
So that when you're caring for someone with pepper spray, I put it under their face while I'm rinsing them, so mace doesn't run down their body and like they get mace all over their body. So this helps control where the mace will go. It just runs into the towel. So like 15 seconds of water, 15 seconds of saline. I'll be like, hey, can I give you some water? Okay, tilt your head, rinse. Tilt other way, rinse. Can I give you some saline? Tilt, rinse, tilt, rinse. And then I'll usually be like, okay, blink, 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 as I'm rinsing. Your beats per minute. And before you do CPR, you have to make sure the patient is unconscious and that they don't have a pulse. So you're going up to the patient, you're like, hey sir, can you hear me? Or hey, person, can you hear me? And like, if they don't respond, pinch their trap. If they don't respond to any painful stimuli, assess their pulse and go like this so you can assess for chest rise as well. So you're assessing their carotid pulse, assessing if their chest rises, assess under their nose if they're breathing. If not, go straight into CPR. But before you go into CPR, tell someone standing nearby, hey, call for EMS backup. If there's someone else nearby who knows how to do CPR as well, get them next to you so they can take over after you finish your cycles. So for CPR, you want to do 30 compressions to 2 breaths. And 100 beats per minute looks something like this. And I don't know if you guys have seen the clip from The Office about like staying alive and that, but like it's like the beat to like staying alive. And it's something like this. 1, 2, 3. So you're gonna do like 30 compressions, and I also carry like usually one of these. It's a non-breathing mask. It's also like, good for like COVID. Make sure like this goes on your patient before you start doing CPR. So you do 30 compressions and then give 2 rescue breaths and then go back to 30 compressions. But when you're giving the rescue breaths, you always have to make sure you tilt your patient's chin up before you give the breaths. So it's like 28, 29, 30, and then like tilt up, give 2 breaths, and then continue. If you don't tilt their head up, they're not gonna get enough air because you're not opening up their airway. And so when you're like, you wanna do about like maybe like 5 cycles and then switch to someone else, because 5 cycles is about 2 minutes, because you're gonna start getting tired. CPR is pretty strenuous and you're not gonna realize you're getting tired, but like you're gonna start slowing down. So that's gonna be really dangerous for your patient. So it's always good to have someone ready to take over after the 2 minutes. Like, don't be like headstrong and be like, oh no, I can do it. Like you're putting your patient in danger if you do that. And how to switch over with someone is that while you're finishing up compressions and going over to do the 2 breaths, you're gonna have your second person over and be like, okay, be ready to switch once I give the 2 breaths. So it's gonna be like 29, 30. I'm giving 2 breaths and the other person has their hands over, ready to begin the next cycle of CPR, so that like you don't lose any sort of like circulation to their heart.
You're doing it right.
I would say just do
It can be traumatic. So if you hear that crack, don't stop. Keep going, because the ribs don't matter. What matters is getting the heart started again.
Talking about the steps you take
If you
right
wanna
before
record them over there, if you're
CPR, check
recording,
the airway, see if they're breathing, check their pulse. ABCs, that's a fun mnemonic, airway, breathing, circulation. It is? See? I'm all, wait, can you,
what is it now?
Can you, yeah.
You want to do
CAB.
compressions first, and then you do your breaths.
And also, I forgot to add, when you're assessing the patient,
Just to check before you start compression. You check the airway. Breathing, or you start compression before you check the airway?
So you check for no pulse. After no pulse, you check for no breath. If
Okay.
you have no pulse, no breath, then you start
Yeah, okay,
compression, 30,
okay.
and then 2 breaths.
Circulation, breathing.
and when you're first assessing your patient, you always want to assess their airway too. So like, open up their mouth, see if there's like any like vomit, any sort of like, you know, anything in their airway. If there's anything, take 2 fingers and then scoop it out as best you can to make sure their airway is like clear, open, and maintainable.
Oh,
Yeah.
I was gonna say, one of the things I learned.
It's like you're gonna see if they're awake. If they're not awake, you check the pulse, and then you're gonna check for breath, and then you're gonna go. So like within 15 seconds, all those 3 checks are done, and you're moving on and you're starting your intervention.
Is it circulation, airway, and breathing?
Breathing, yeah.
Yeah, okay. When you're doing CPR, like if you don't open someone's airway up properly, what's gonna happen is that like when you start doing the breathing for them, you're going to push that air into their stomach instead of their airway, and then that's gonna make them throw up. And it's gonna make them throw up, and it's also like just not helpful. And you can usually tell because you'll see their stomach will start to rise instead of their chest. Correct me if I'm wrong. Yeah, just be aware of that, because if you make them throw up, it's gonna make your job a lot harder.
Can you describe how you're blowing into the mouth if you don't have one?
If you don't have one of these, you can do mouth to mouth, but if
It's
not,
like-
you can also just do this. But yeah, like any sort of like seal you can do.
Like, how much breath are you blowing into?
One whole rescue breath, just like one breath. Yeah.
Yeah, you give them 2 of those.
Yeah.
Understand that anytime you're doing mouth to mouth, you have a COVID risk, so that's really going to be a personal choice of whether or not you're going to assume that role. And so if you're not comfortable with that, just do your compressions. Just keep doing compressions until you get someone there that can help you. Because even with a barrier, unless it's one of these, there's going to be a COVID risk. There's a risk of COVID regardless of whatever. So just be mindful of that.
And what are those called again?
This is a valve, a respirator. It's a mask respirator. Yeah. I think I might have a few more. So it's like if anyone's a medic, just hit me on the DMs. I'll leave my info with Triage, and I'll try to get you a couple before the end of the week. So you have probably 3 or 4 more circling around.
Also, there's pens up here if anyone is like taking notes. But I'm gonna show you guys like one cycle, and then there's gonna be like gloves up here. I'm gonna give you guys like 10 minutes for people to like get snacks and also like practice if you want to. It's gonna be like this. And count as you're going, so you know you get to 30 compressions. Tilt the head back, 2 breaths, and then continue. Okay, so
And is a rescue breath like blowing air into the balloon, like that kind of?
yeah, just blow air in. Yeah. Okay.
Is there a specific like aim position that you're going in?
I usually go like this. Okay, but yeah, come practice. When you're assessing for major bleeds, always try applying direct pressure first. So say like someone got cut right here, assess how much the bleeding is and apply direct pressure. Don't lift your hand up to like check if the bleeding has stopped, because that's gonna release the pressure that you have on the patient already, and they're probably gonna start bleeding again. So say like someone got cut right here, apply direct pressure according to how big the wound is. If it's like a bigger wound, I wanna say apply direct pressure for like 2 minutes first before lifting up to check. If it's a smaller one, obviously you might need like less time to do that. If the bleeding is on an extremity, like an arm or a leg, try applying direct pressure first. And if that doesn't work, like if the bleeding is really, really major, then use a tourniquet. And I'm gonna explain how to do that after. But also, if it's on an extremity, you can also elevate the bleeding site so that less blood goes towards the extremity. So like, say someone's like bleeding right here, then lift their arm up while applying direct pressure, and that will help the bleeding stop, hopefully. Okay, so when you're using tourniquets, these tourniquets, they're only use them when you can't control a major bleed, because they're very dangerous to use. Someone could lose a limb from you using a tourniquet. I would say always apply the tourniquet at least 2 inches above the wound. If someone got cut right here, and the bleeding hasn't stopped, apply the tourniquet about right here, so like 2 inches above the wound. But if the bleeding is like right here, 2 inches would be about at my joint. Don't apply the tourniquet at a joint, because when the patient flexes their arm, that's only going to move the tourniquet. So apply it a little bit above the joint. And when you're like assessing like arterial bleeds, for example, direct pressure is not going to work. So go ahead and use a tourniquet. You're going to know if it's an arterial bleed, if it's like squirting blood. You'll know because it's like just squirting blood. So for tourniquets, they look like this. They look like this. The rod is going to be on the outside, and how you put it together is just like this. Make sure the rod is on the outside, and then put it on someone's arm, strap it in, give this rod at least 2 turns. If the bleeding doesn't stop after 2 turns, just do more turns until the bleeding stops. Place the rod in place. There's going to be a low hook right here that you put the rod into so it stays into place. Wrap this strap around, and I would say try to make sure the wrapping goes under the low hook. So wrap it around, make sure it goes under the low hook, because sometimes this strap may be hanging, and then like it'll get caught on something and someone's tourniquet comes off, and then like the work you've done is like they continue to bleed. But yeah, and so you strap this down. There's gonna be usually a time thing on it. Make sure you're carrying like a little marker. Usually when you're carrying a tourniquet as well, you're gonna want to write the time on it, because usually after about like 4 hours of a tourniquet on, someone is probably going to lose their limb because they're not getting enough blood to that site. So you want to make sure you have the time on so the next person taking care of the patient knows how long that tourniquet has been on. When you're dealing with gunshot wounds, you want to apply the tourniquet at the very top of the extremity. If someone like got shot right here, don't apply the tourniquet right here, because sometimes the bullet may bounce around in someone's extremity, and they might have like bullet shards like up here, or like internal bleeding up here, like way above the site that you might not know of. So always apply at the very top of the extremity when you're dealing with a gunshot wound. When you're dealing with a gunshot wound on an extremity, also assess for an exit wound on the back. See if like the bullet stayed in someone's like extremity, or stayed in like, or if it came out. But even if you see an exit wound right next to the entrance wound, you're still going to want to apply the tourniquet right up here, because you don't know how much damage the bullet has caused in someone's extremity. But yeah, I'm going to have her talk about dealing with gunshot wounds.
I'm going to follow up on a couple things with the tourniquet really fast too. So this is a tourniquet that's ready to go. Oh, sorry about that. So my name is Hale. I got some of my medical training in the Marines. I'm a combat lifesaver certified. And like most of our focus was on like extreme trauma from explosions and gunshots. So this is a ready to go tourniquet. It's ready to go because the strap is already put through the loop. When you buy a tourniquet, it's going to come like this. Actually, this one's also all prepared as well. It's usually going to come just folded up. It's going to take you extra seconds that could cost someone's life to have to try and thread this while your adrenaline's flowing and while their blood is flowing out of their body. I personally think that as the environment heats up and we have to deal with chuds who might be walking around LA with rifles, everyone should have one of these in their individual first aid kit. We used to carry 2 or 3. We would have one in our IFAC, one in our cargo pants, and one in our upper shoulder to keep it as close to the extremity as possible. And we'll get more into IFAC usage and deployment later, but
Always remember that if someone has their own IFAK, pull from their gear first. So this is called a Cat 2, I'm pretty sure. It's the newer one, and it's made out of plastic. So unfortunately, this rod can snap. So when you're twisting it after you've applied it to someone, make sure that even though you do get more leverage from the outside, try and turn as close to the inside as possible. Because if you didn't apply it to the outside band tight enough first, you might need to turn it more times than this piece of plastic can handle. Too much torque for it. So always when you first apply it, make sure you're getting this as tightly on yourself or on someone else as possible. Like it should be uncomfortable when you first put it on them. Because you can't loosen it to adjust it. Once it's already on, if you let go after you've already built up some pressure, the amount of blood they could lose in that like second or two could kill someone. And again, like they were saying earlier, you always write the time on, and it's not just because they could lose a limb. The body starts building up like a toxic chemical, essentially, a stress chemical, at the end of where the tourniquet is applied. And after 2 to 4 hours, a surgeon, a lifesaver, is going to have to like inject a life-saving chemical to counter that chemical being released in the bloodstream to stop a coronary heart attack. So everyone needs to get a tourniquet pretty much as soon as possible if you think you're going to be in life-threatening, violent, combat-like scenarios. And practice on yourself. Ideally, you should be able to do this with one hand, because what else are you going to use if you're all alone and you got your arm shot or shot off? I think that's all I want to say about the tourniquet for now.
Yeah, a couple short notes.
Yes.
One is don't practice with the one in your kit.
Yeah.
It degrades with use. It won't be strong enough to work when you need it. If you practice with it, use some of the ones that we have up here to practice. Get good at it. It's not hard, but just like with CPR, you need to push hard. You need to be ready to cause some pain to get that thing on right. And once it's on, if you decided to use it, you're deciding they're losing that limb. Once it's on, if someone takes it off, they're probably going to die. Don't let anyone take it off. It doesn't matter how much it hurts. Pain is the patient's problem. You're trying to save their life. So like it's really serious. They can't decide. They can't be like, oh, it hurts. Take it off. Take it off. Absolutely not. It'll kill them. And if you have to restrain them to enforce that, do it.
Yep.
Hey, Hal. I didn't hear earlier if it was covered, but I was taught to always have a Sharpie as well to write the time on their forehead.
Yeah, I've seen that as well. It's just that when you write on the forehead, like sweat and blood and dirt can get in the way.
Okay.
So this is nice because it's just labeled time on there.
Okay.
And I think that having the time on the forehead is probably more for like Army medics and Navy corpsmen because they're used to looking for that.
Okay.
Whereas an ER surgeon might be like, what is this number on this person's forehead?
Okay.
But this is pretty clear.
I've heard if you put one on, and you over it down, and it doesn't, the bleeding doesn't stop, don't reset it. Add a second one.
Yeah. That's what I was saying earlier. Never undo the plastic like handle, and never undo the Velcro strap. You can definitely apply a second one if you notice the bleeding hasn't stopped.
If we don't have a tourniquet like that, like what's a safe option? I mean, I've used a belt before, but like, is that safe? Should I not just be like making it work? Like,
you should only resort to a belt or something as a last resort. A lot of belts aren't even gonna cut it, honestly.
I mean, it didn't
because you're gonna have to hold it the whole
It
time.
didn't really work that well, but like literally I had nothing. So like I was just wondering if there's alternatives or like if there's something specifically that's not safe that I shouldn't be doing.
You shouldn't use anything flexible. Like I've seen someone suggest, oh, what about like leggings or pantyhose or like something ripped off of a shirt. Extra last resort because you have to pull tight enough to beat the elastic of it. This has no elastic. A leather belt would have no elastic. But with a leather belt, like you don't have a way to secure it. You're gonna have to be holding that against the patient's leg until EMS can arrive and apply an actual tourniquet. So again, last resort, but if someone's leg's falling off, or they've got like a gushing wound from an artery in their leg, you're gonna do something. Like they were saying earlier, like Echo was reaffirming, the patient may lose whatever is south of the tourniquet. And so that's why we'll get into gunshot wounds in a second, but that's when you're going to be most, you have to be most aware of where the wound might actually be. If someone has a clean break on their leg, like their foot got blown off somehow, you could stop right here, assuming that the bleeding stops. So that's when you're going to be constantly assessing and reassessing. Like, is the patient still bleeding? Yes? Okay, then tourniquet up higher. Make sure you skip the joint every time because there's just too much movement for that. And then also sometimes these straps are pretty wide, but you might have to deal with a patient whose leg is bigger than this. And so if you can't get all the way up at the top of the thigh, you might have to go lower. Does that answer your question? Okay. Any other questions?
Oh,
To add, go ahead.
sorry, just how to arrange them for quick release.
So, excellent question. Did everyone hear his question?
I didn't. I'm deaf, sorry.
Okay, so what he was asking was how do we arrange this for quick release so we can easily and quickly deploy it? Make sure you have the plastic tab handle already in the little catch at the top. Make sure that your strap is already threaded through this little buckle. And then I wouldn't keep it very tight so you don't have to open it up too much. Have it like secured and then folded. So that way you know I can just like whip it out. All I have to do is slip it over someone's arm. And again, it'll save you a couple extra seconds, but those couple extra seconds could be the difference between someone dying versus losing a limb versus getting out of there okay and having a full recovery. Does that answer your question?
Yes, thank you.
Any other questions? Oh, you said you had something you wanted to add?
If you have to add a second tourniquet, go higher than the last one.
Yep. Okay, so we're going to move on to GSWs.
What's a GSW?
A GSW is a gunshot wound. Thank you. So there's a lot of different types of gunshot wounds because there's a lot of different types of guns and Americans have a lot of them. The ones that we're most likely to experience from the police are going to be 9mm or 45 caliber pistol cartridges or 5.56. 5.56 comes from an AR-15 or an M4 rifle platform. That's also what a lot of Chuds have. It's the most common weapons platform in the country. They're all over the place. And they're incredibly dangerous, not just because they're a high velocity, accurate round, but because when the round enters the body, you might not be able to tell where the exit wound was, if there even was one. The round is very small and it tumbles when it enters the target. So that's why if you could even have a patient who was shot in the arm and not see an exit wound because it blew out their side somehow.
No.
Yeah.
Stop.
Yep.
Sorry guys, I can't.
Side note, if you're squeamish, I don't know how to work on that.
If you ever see me on the ground doing medic shit, come help me. I'm not good at this. I've had extensive training. I freak out. I'll run into gunfire, but medic's not my thing. I came because I should refresh myself and be with like on everyone here right now. You see me helping somebody, it's not going.
You can be the hype man for whoever's doing the medic
like,
stuff.
I got this.
Yeah,
Like,
get that
I'm
tourniquet.
doing
Yeah.
But like, it's not me. I'll do it if it's necessary. I was the only one on the ground the other day to do it. But like, y'all please help me. It's not me.
So when you come up on your patient who has a gunshot wound, assess the level of bleeding that they have. You can bleed out from a gunshot wound even if it's not arterial. So evaluate their extremities. Again, like if you don't see an exit wound, that means the bullet is still in the body. And we're not going to have the training to necessarily deal with that immediately, especially if it's somehow gotten into their internal organs. But definitely, if you have a gunshot wound on an extremity, confirm where the exit wound is because you don't want to tourniquet too low on accident. That's going to be more of a problem on a leg. Like if you get shot here, you can have the exit wound blow out there. Leg wounds and arm wounds can also have entry wound, exit wound, and a second entry, especially with a 5.56 or a 223 from an AR-15. 9mm and 45 caliber, even though they're like wider rounds, are actually safer to get shot with, because they're more likely to have a clean entry and exit. Not that you're probably going to notice that much about like, hey, excuse me, I see that you got shot. What kind of gun were you shot with? Just for your situational awareness, and just for your understanding of the types of gunshot wounds you can have. One thing the cops do not use anymore, because they're not allowed to for the most part, is buckshot rounds from a shotgun. Shotguns are also incredibly cheap and spread out all over the country though. So when we're talking about coming up against MAGA chuds and 3%ers, they could have those out there too. I'm going to cover shotgun wounds really briefly because they're very difficult to treat. A 12 gauge double-aught buckshot round has the potential, if close up, to blow a limb off if it's really close to the end of someone's limb. We're not really going to be capable of treating that much if it hasn't blown a hole in someone, because they're steel BBs that punch multiple little holes. When I was doing pig training on a live pig, they shot a pig with a shotgun from close up, and we weren't able to save the pig's life, and the instructors came over and confirmed, like, well, yeah, there's too many holes, like you're not going to be able to handle this on the ground. They would have to be airlifted out of the area. So shotguns are incredibly lethal for GSWs being treated on the ground. That's going to be, I mean, these are always going to be like call EMS immediately situations, but shotgun wounds I'm especially afraid of. If you have a wound in the like torso area, obviously that's more lethal for like long-term possibilities because you don't know which organs may have been punctured. Sometimes they're actually really clean in and outs. The way ballistics works inside of a person is organs can get pushed out of the way by the trajectory of the bullet. So sometimes it's actually an easy survival compared to getting shot in the arm and having an artery blown out. Before you tourniquet someone, if they've been shot in an extremity, you're going to do your best to try and stop the bleeding by packing the wound. If you have something like quick clot, that's a substance, a powder substance that you pour directly into someone's wound, and it cauterizes it from the inside. It's incredibly painful, but also incredibly effective. The military stopped using quick clot because it was difficult to deploy when hands are covered in blood. You have to tear open a package and pour it. So they developed something called combat gauze, right? Yeah, pretty straightforward. Combat gauze is like regular gauze, but it's laced with a quick clot-like chemical that you can just pack into the wound. Excellent. So this is excellent because you don't have to focus too much on, you are never going to have to focus on trying to get a bullet out of someone's body. Never ever try and think about that. Don't go digging around with your fingers. Don't be getting your like gauze shears out to try and dig it out. You're just going to cause more harm than good. Wait until they can get in front of a surgeon. Quick clot can be used to just stuff the hole inside someone's body to make sure that they stop bleeding. Some gunshot wounds could take more than 1 or 2 of these rolls of gauze, especially if it's in their leg and they have a large GSW, like cavity. When you decide to use a tourniquet after applying gauze, that's going to be like a split-second decision. I've already packed 2 of these things into this person's leg and it's still gushing blood. Stop fucking around and get the tourniquet on them. Don't let them die. I wasn't super prepared to speak on everything today, so if you have anything you want to jump in with GSWs,
yeah,
help.
so
Appreciate it.
When you're packing the wound, have a second person helping you, especially if it's a gunshot wound, set the tourniquet up.
Yeah.
And the person who's pushing the gauze in should be applying direct pressure on the wound still. If it's still bleeding through, keep direct pressure on, have that second person apply the tourniquet. You want to keep that pressure as long as possible because once you release, it's going to come gushing, and that could really quickly lead to them going unconscious or losing a lot more blood than they were ready for. Let's see. For abdominal wounds or chest wounds, we have these chest seals. Is that what you're going to? Yeah. Okay. Yeah.
So I was going to refresh myself with this really fast. So 2 things before all the packing and stuff. All of these principles are about applying pressure to a leaking arterial system. So a tourniquet is applying pressure directly onto the artery to stop it from leaving the artery. Packing wounds is about stopping the like applying pressure to the end of the artery where the blood is already leaving. If someone has a small enough wound, or before you can have a kit brought up to a gunshot wound patient, again, just start applying pressure immediately, because that could be life-saving as well. Like when we were at the Lakers riot, and I saw someone who got shot in the neck, and he was just like squirting blood out. I didn't have a kit on because I was at a fucking celebration. I didn't think the police were just gonna start shooting people in the face. So I just put pressure on his neck until a cop felt like kicking me off of the patient to take 5 minutes to apply gauze. But even though those cops were idiots, they understood the process. Apply pressure and then apply gauze. Let's see, so, elevation's also on here. Blood is under just as much effect of your internal pressure system of the heart as it is under the effect of gravity. So just like with any injury, you want to elevate the injury so you're not giving more gravity to cause the blood to travel out of the body faster. Another excellent piece of medical equipment for GSWs that should be in everyone's individual first aid kit is a chest seal. It's generally used not on the abdomen, but above the abdomen in the torso. The torso is actually quite a pressurized system, and anytime there is a hole poked into the torso, it modifies that pressure, especially if the hole that entered the bullet that entered the torso also entered the lungs. That can cause a release of pressure from the lungs into the chest cavity, and it can throw things off, and that pressure can put pressure onto the heart and cause the patient to go into shock and death faster. So what a chest seal does is it seals off that hole in the chest cavity that is causing pressure to leave, but it also has a little nozzle on top of it that allows pressure to leave naturally. So the chest naturally starts to stabilize itself, the pressure system inside the chest cavity. The instructions are right on the back. It's like an adhesive seal, so you need to make sure there's not excessive blood and dirt and debris in the way. You tear off the backing on here, apply it directly. And before applying for a chest seal, you can also you can hear the air leak going in and out of the chest. You can hear the leak. So confirm that there is a leak before wasting a chest seal, or go for it anyway, I guess. Suppose it can't cause any harm. Anything else you want to add on the chest seal?
There used to be old information about how many sides you seal. For these, just seal the whole thing over, all four.
Oh, that's right, yeah.
If they're having some difficulty breathing, it might be because the valve's blocked off or there was too much caked blood. You might need to lift one side a little bit to restore their breathing. That's if they're conscious and responding. If they're not and their breathing starts to go, you're gonna leave it on and go back to CPR. You can use chest seals for abdominal wounds if the wound opening is smaller than the seal, but normally you'd want to start by using wet gauze to pack and apply pressure, and only after you can't control bleeding then you can try it. It's better than not.
I'm glad you brought up the abdominal wound as well. I'm sure we've all seen movies where someone's been eviscerated and their guts are spilling out. The abdominal wall is much less protected than the sternum, and if there is a gunshot wound or some sort of laceration caused by an explosion in the abdominal wall, you can have that sort of guts exposed to the open air situation. It is far less dangerous than having the chest seal breached, or the chest cavity breached. Very fortunate to have never seen it except on a pig. Not a cop, a pig. I know, I'm sorry. You won't be, if someone has a 4-inch incision with their intestines spilling out, you will not be able to close that appropriately. You won't be able to do it. They can still live though. It's gonna be gross. With gloves on, put their guts back inside, pack their abdominal cavity with gauze. Wet gauze, like you said, because it's more likely to cause a seal with that much of an opening. They're not going to be bleeding profusely like they would for a torso wound or an arterial bleed in their leg. It'll be gross, but this is where you find the least squeamish possible person, not this one, to help you out. We even got told, if it's really bad, lay the patient down, grab the open flaps and shake their guts back inside. Yeah. Shake their guts back inside. They will fall into place naturally. Yep. Don't worry about sealing it up. If you have a bunch of tape, you can try and cover it up, but it's just going to be a waste of time. Just
Should we leave them prone? Is that a stretcher situation?
Yeah, you're going to be wanting to get them out of the area immediately after that. And they're not going to be ambulatory because then they could spill back out. I'm so sorry.
Quick walk or things like it. I've heard that it doesn't really work well on abdomen or chest, really for like muscle areas.
Yeah, they're definitely more for the extremities. I wouldn't pour a quick clot into someone's abdomen. That'd be horrifically painful, and I think it might even cause more harm than good. The part of what makes combat gauze so effective is it's like soaking up blood really quickly versus like regular gauze, which takes an extra split second. So yeah, I wouldn't put it into the abdomen because it's not going to be bleeding that much anyway.
Yeah, I've heard that like you need to like wound pack. It'll just keep filling in around the intestine.
Right, but like if someone has a laceration or a gunshot wound to their abdomen, and you can't necessarily see like what may have been punctured, someone's stomach, someone's kidney, someone's liver, etc. I would rather have someone packing a bunch of regular gauze inside than just doing the old gut shake thing and hoping they're going to be good.
My question's also about the combat gauze. In the event that you were going to have to use two tourniquets, like if we started lower, we would have already packed.
Yeah.
Used one tourniquet.
Yeah.
Before we use the second tourniquet, do we pack again or just immediately go for second tourniquet?
You're probably not going to be continuing to pack because you're going to see that it's still bleeding even though the wound's completely packed.
Okay, yeah.
And so at that point because you have an assistant around, you've got someone holding pressure on it, you get the first tourniquet on, so release some pressure, it's still bleeding, hold it again, and then add the second tourniquet.
Okay, thank you.
You're welcome. I'm so sorry.
Is there any way to seal or
If you have extra equipment, like Echo was saying, you could probably take a chest seal or two and try and cover it up. I think for our situations, we're not going to be so bereft of supplies in these situations because we're not going to have like hundreds of people getting wasted. So if you have two chest seals, go for it. But they're not that in danger from like blood loss in this situation. They're in danger from hypothermia because they're rapidly losing their internal body temperature. So it would be more important to get them covered up with a blanket and on a stretcher and out of the area. Yeah, start training for shock. Oh, that's right, they do, huh? Do these ones?
Yeah.
Wonderful.
Cute metal ones.
I want to add for gunshot wounds, when someone's shot, do not give them anything to eat or drink, especially if it's in the chest or abdomen area. If you're dealing with an evisceration, which is when like someone's internal organs are showing, if you have saline, take some saline, some gauze, spray some saline on the gauze, put that on the evisceration, and then seal with an occlusive dressing, which is also what a chest seal is. Yeah.
Thank you, that was much more clear than me.
Inclusive dressing, if you could go over it, they some sort of rough and
Yeah, Echo got that.
And when did you say like hypothermia was a risk again?
That's a risk for any gunshot wound.
Okay, so
So I mentioned it specifically for the like evisceration or sucking chest wound scenario because your internal body temperature is maintained with your like internal pressure system, and once that's breached, like you start losing heat through oxygen loss.
Okay.
Not just oxygen, just the air spilling out, whatever that is.
With packing the gauze in, it's like with the CPR, you're pressing really hard, it feels really gross, shove it in there. Just pretend it's not a human, like really get it deep in there, because if you kind of pussyfoot about it, it's not going to do anything, you're just wasting the gauze and a lot of their blood. Shove your fingers inside of their body with that gauze on your finger, and keep doing that until you can't press any harder.
So
and if you run out of room, get another gauze.
In following weeks, we're gonna have like more specific training where everyone will get to practice this. We'll come up with a fun way to do it without having to shoot someone first.
It's okay, you can shoot.
Excellent. How many times can we shoot you? We'll find out.
One of the things I was talking about practicing wound packing, you get like a pool noodle or like a length of like pipe insulation, you can cut a laceration under that, and it'll give you a nice like tear, and you can work your fingers into it.
That is fun. I was gonna poke a hole in a melon, but that works too. Probably less messy.
Different muscles.
Yes.
The melon might be a little bit more visceral.
Right. We'll do a watermelon for this one over here. Yeah.
Please don't get shot.
We'll get a pool noodle filled with jelly.
Do you feel comfortable spending a moment on triage with gunshot wounds? So let's say you have multiple issues or injuries. What's the order you should treat them?
Oh God. I'm honestly gonna need a little help on that one.
Sure. Okay, so someone's got gunshot wounds. They're not conscious. You think they might not have a pulse, or they're not breathing. They're bleeding out. Where do you start? Bleeding. Bleeding's the #1 cause of death. You can go a few minutes without oxygen. You can keep doing CPR and someone can shock the heart. If you've bled out, you can't put the blood back in. That's it. So start with bleeding. Call for help. Obviously, yelling to someone, get EMS. Once you're treating for the bleeding, someone might be able to start with Airway or start with the CPR. But getting the bleeding under control is always your #1 priority. Once you've done that, then it's pulse and breathing. And then after that, any other like minor issues like broken bones. If they get gunshot wounds and there's a fragment of their bone sticking out, you're treating them for bleeding. The broken bone doesn't matter yet. So that like mental triage, being able to go down the checklist of what you should be checking for, always bleeding's first.
I thought have like a mark.
What's up? Yeah, there is.
We'll have a mark.
Oh, yeah, that's right. We have the cards.
Oh, there's cards with
Yeah,
marks
so
on
we got these
it.
cool little
Nice.
laminated info cards.
Yeah.
Go ahead. So, just like Echo was saying, this is a triage card, very similar to the one that I was using in the Marines too. Did you get this from EMT services or?
Actually, I had the like 9 line.
I got the 9 line? Yeah. So the acronym that we use is MARCH. Massive hemorrhaging, airway, respirations, circulation, and hypothermia. So massive hemorrhaging being like you're bleeding a lot. Airway, again, like Echo said, so if someone's not breathing, it doesn't matter if they're bleeding to death. But it will be the next thing you treat because it doesn't matter if they have broken bones if they're not breathing. Let's see. And it separates airway and respiration because if someone doesn't have an open airway, like I think, who brought that up earlier? If you start trying to treat someone who is not breathing and you start giving them rescue breaths, but their airway is blocked, you're going to be breathing air into their stomach instead of their lungs, and they will vomit instead of breathing again. So stop the bleeding, start the breathing by opening the airway and treating any sort of injuries that could stop them from breathing, be that lungs or otherwise. And then circulation is the next step. That's looking for signs of shock. So I feel like that's a whole section on its own. You're prepared to start talking about shock. And then hypothermia last, because again, if someone is going into shock, that's most likely a loss or caused by them having a loss of blood, or they have a significant opening in their body, and they're starting to get very cold very fast by losing their internal heat temperature. Yep, that's all I got for triage.
So much.
You're welcome. Thank you.
Okay, so now, yeah, thank you. So that was Hale. Thank you so much. So now I'm gonna go over basic trauma assessments. This is gonna be like a basic head-to-toe trauma assessment. And when you're doing this, you're only assessing for the severity of your patient's wounds and the severity of your patient's conditions. You're not going to be able to completely heal your patient, but this is just for you to assess the situation and how much help your patient is going to need. Usually when you're doing a basic trauma head-to-toe assessment, you're already going to want to call for EMS backup, because if you're doing this, they're probably not in a good situation. So how you start is you start at the head. You always wear gloves. You always want to make sure you have PPE on. Start at the head. Do a glove sweep through the back of the head. Run your fingers through the back. The things you're looking for during a trauma assessment is it's going to be deformities. It's just like any area of the body that's deformed in a way that it usually wouldn't be. Deformities, contusions. Contusions are any sort of bruising. Abrasions. Abrasions is just any sort of like scrape. Puncture wounds. Burns. Lacerations. It's just like a big cut, big gash. Tenderness and swelling. So you're assessing for this in all areas of the body. So start at the head. Take your fingers, do a glove sweep through the back. Check your gloves for any blood. If they're bleeding, you're gonna be able to see blood on your hands. And while you're checking this, check for any deformities, check for any like lacerations, any cuts and all that. And then after that, you're gonna check the ears. Check the ears for any blood or CSF fluid. CSF fluid is like fluid like from the brain. So if they have like CSF fluid leaking out, that means they're probably dealing with head trauma. CSF fluid is usually clear, or it can be like yellow at times. So you're checking the ears for that. Check the back of the ears for battle signs. Battle signs just looks like big bruising. You're gonna see, if you see like bruises behind both ears, that probably means your patient has like a head fracture. Check the eyes for like raccoon eyes. Check the pupils for dilation. If you have a pen light, shine a light into the pupil, see if it dilates or not. Check the nose for any fluids, and check their mouth. Open their mouth, check their airway, see if there's anything lodged in there. Check their teeth. If they have any missing teeth, it might be lodged in the back of their throat. If there's anything you can scoop out with your hand, just do a 2-finger glove sweep and get it out. But check that the airway is clear, open, and maintainable. If it's not clear, open, and maintainable, that should be your first priority, because if your patient can't breathe, they might die. Yes? Oh, sorry. Yeah, so after you check the head, move on to the neck. Check the neck for any medical tags that might give you any insight onto their condition. Check the back of their neck, so feel the back of their neck, because you can feel, yes. Sometimes if they're in shock, their eyes aren't going to dilate, or you're also just checking their pupils, checking their eyes to see if any eye is like blown out or all that. If their pupils aren't dilating, that's not going to be your biggest concern. Just move on. Just make a mental note of that. So when you're checking the neck, check the back of their neck. Like feel their spine. You know like how your neck feels like, and if there's any step-offs, like you're gonna be able to feel that. Any like sort of like bone in the spine that's out of place. And then you're gonna move on to the chest. So again, you're checking for like any deformities, contusions, abrasions, punctures, burns, lacerations, swelling. I know that's a lot to remember, but just like anything you see that is off. So how you check for like broken ribs or like any like flail chest. Flail chest just means like 2 or 3 or more ribs are like broken off from the chest cavity. And you take your hands like this, do a barrel hoop motion like this. If they have like a flail chest, you're gonna be able to see their chest move. You're gonna feel the ribs moving. And when you're assessing this, so when you're assessing this, you can't do much for them. You're just making that mental note, and like you're just assessing the severity of their condition. So you're gonna move down to the abdomen area. That's where most of your internal organs are. Take your hands like this and do a fishtail motion. Palpate their abdomen like this. If you feel any sort of like heat, if like you feel an area that's like really hot, that probably means their internal organ is infected. Again, there's nothing much you can do, but just like make a mental note of that. And if you like feel any part that's like really hard as well, that means like there might be like internal bleeding, like something like that. Something's wrong with their internal organ. And scan at the pelvis, you're gonna do these barrel hoop motions down the area to see if they have like a fractured pelvis. If like they have a Fuchs fracture, which is a fractured pelvis, you're gonna be able to feel that when you do the barrel hoop motions. And then you're gonna move down to the extremities. So for all of the extremities, you're gonna want to assess for PSMC, which is pulse, motor response, sensory response, and capillary refill. So what this means is that this is gonna be the patient's hand. I'm gonna assess both pulses at a time. Like if they have like both arms like this, I'll take both radial pulses at a time. Pinch their finger, be like, can you feel this? That's their sensory response. Can you wiggle your fingers? That's their motor response. And then press their thumb. That's for a capillary refill. So when you press your thumb, you're gonna see the blood rush back into the thumb. Usually it takes about 1 to 2 seconds for the blood to rush back into the thumb. You're gonna see, the color return. If it takes more than 2 seconds for that blood to refill, that usually means something is wrong with their blood circulation. So just like make a note of that as well. So when you're assessing both extremities in the arm, first do PSMC, assess for pulse. Can you wiggle your fingers for me? Motor response, can you feel this? Sensory response, and then check for capillary refill, both at the same time. So you're like reducing the amount of time you spend on the patient. And then when you check the extremities for any fractures or like broken arms, you want to do offset pressure in the extremities. So that it's gonna look like this, pretending this is the arm. So like when I assess my leg for offset pressure, it's like this. Just like do that. If it's like broken or like there's like a severe fracture, you're gonna be able to feel it or like see it move. So I'm just gonna like run through this one more time. So like start at the head, glove sweep, check your hands for any blood, check like also like for any like cuts, abrasions, bumps, all that. Check the ears for any CSF fluid or blood. Check the back of the ears for battle signs, which is for skull fractures. Check the eyes for raccoon eyes, blown pupils, or anything like that. Check the nose for fluids. Check the mouth for like a compromised airway, or like dislodged teeth, vomit, all that. Check the back of their neck for any step-offs. Check the neck for medical tags. And then if you like see a cut or anything, address it as you go. Don't come back to it. The point of a trauma head-to-toe assessment is also just like you're assessing and like taking care of the problems as you go, so you don't forget about it. And then when you're assessing the back, like for example, if like the patient's shot or something, usually you're gonna lay the patient supine, and you're gonna have someone help you turn the patient over. You usually want 2 people to help you do a log roll over, so you can check the patient's back. And the 2 people helping you roll the patient over, they don't need any sort of medical experience. You just need to tell them what to do. So I'll be like, hey you, can you like help me turn this patient over? And I'll be like, place your hands like this, one at the patient's like pelvis, one at around their legs, and the other person is gonna hold your patient's head. So your patient's head and neck is stabilized as you turn the patient over. This is really important because if you don't do this, that could give them like additional spinal cord or neck injuries while you're turning the patient over. So pretending I have 2 people helping me, I'll be like, okay, on my count of 3, we're gonna turn the patient. 1, 2, 3, turn the patient over. This arm, you're always gonna have to have it over your other person who is also helping you turn the patient over. Your other person's gonna be like this, and your arm is gonna be over theirs. And you're gonna take this free arm to assess the back for any exit wounds, any cuts, any bleeding, and you're gonna have your medical kit nearby to address this as you have the patient turned over like this. So if you see like an exit wound bleeding, control it right here. And then when you're done with this, be like, on the count of 3, we're gonna release the patient back down. 3, 2, 1, down. So that's how you turn your patient over safely. Any questions, concerns, anything? Okay. Now we're gonna go into like basic medical care. For most medical conditions, you're not going to be able to address it unless it's just like low glucose or like mild shock. Most medical conditions, you just want to call for EMS backup straight away because you're also not going to be able to do a proper diagnosis. But if you're dealing with someone who has a medical condition, first ask them what their the acronym is SAMPLE. Ask them what their symptoms are. Ask them if they have any allergies, especially allergies to medication. Ask them if they take any medications. Ask them about their past medical history. Like, do you have a history of like high blood pressure or like heart attacks? And ask them what the last thing they ate was and when, because that's also usually a big indicator. If someone hasn't had like breakfast, hasn't eaten anything all day, and they fainted, that's, you know, that might be why. And also ask them about like the events leading up to the condition, like what they were doing right before it started, because that can also help you assess the situation. So I usually carry around one of these. It's a glucometer. I'm sure most of you might have come into contact with one. This is what it looks like. So press any button to turn it on, and you're also going to have this tube of like test strips. I'm going to show you guys how to use this. So this is what a test strip looks like. It's just like a little strip with a little thing at the end. Place it into your glucometer with this tip side out. You're also going to have this like stabby thing. It lets you control how deep you want to puncture your patient. I usually use 5 because that's just like for like softer skin it'll go through, for normal skin it'll go through. If it's thicker skin, you can move it up to 10. But yeah, adjust the depth you need. And it's also going to come with these like individual needles. Put it into your stabby thing and just like twist it off. I'm not going to do it for this one, but twist it off. And then you're just going to place it next to your patient's finger. Always do the side of your patient's finger, not the middle, because the middle has more nerves and it's going to hurt more in the middle. So do it at the side where there's usually more calluses, and just like poke them. And then if a drop of blood comes out, just like place it at the testable blood. But if a drop of blood doesn't come out, then like squeeze their fingers a little bit and a drop will come out. But test their glucose. Normal glucose level should be at around 80 to 120. If their glucose level is higher than 120, there's nothing you can really do for them. Advise them to go to the hospital immediately because that's the only place where they can address that. But if their glucose is too low, like below 80, I would go ahead and give them one of these glucose gels. Go ahead and give them the whole thing, or yeah, go ahead and give them the whole thing. These tend to be like more expensive, but you can also just like use like cake icing or like things like that. Cake icing actually works really good. It's like kind of the same thing as
I like pixie sticks.
Yes?
I use pixie sticks because pixie sticks are powder. You can't choke on them if they're unconscious. You can just put it in their mouth. You get pixie sticks at the Dollar Tree for $1.
Yeah. Also pixie sticks.
If somebody saves me with a pixie stick, I think I can get through.
So for shock, signs of shock are cool, clammy skin. Feel their skin first. If their skin feels really cool and clammy, if it feels a little bit moist. Also check their lips, the inside of their lips and their fingertips. Check for like any cyanosis, which is like lack of oxygen. It should be like a bluish color or a grayish color. It depends on the complexion. If it's darker complexions, it's usually a little bit more gray. And check for a rapid pulse, rapid breathing. assess their like carotid. You can like assess it. You can reduce time by assessing, like just check their carotid pulse, chest rise at the same time, and you also get to like feel under their nose for their breathing. So yeah, and like anxiety and nausea are also signs of shock. Shock definitely varies in different people.
They're checking their cars because they're starting to ticket. Go check your meters.
I didn't pay for mine.